Welcome, everyone. I know people are just starting to sign on for our webinar, so I am absolutely delighted to welcome everybody into this space. We'll be kicking off in just a couple of moments, and in the meantime, just get an opportunity to chime in. We'll be kicking off formally in just a couple of minutes, so I'll give everyone a second to sign on. Thanks. Well, as folks are coming right on into the webinar, I want to just take a moment to really welcome everyone into this space. We have guests and participants from all around the world today. So whether it's good morning, good afternoon, good evening, we're so excited to have an opportunity to connect with you through this webinar. I'm Michelle Decker. I'm a professor at the Johns Hopkins University at the School of Public Health, and I have the pleasure of being our director for our Center for Global Women's Health and Gender Equity. And I'm so delighted to welcome you this morning and this afternoon and evening to our webinar, Evidence in Focus, Emerging Research on Gender Equity and Gender-Based Violence. Today's session is going to present some really exciting and important evidence from Bhutan, Mongolia, and Sri Lanka. And as we move through the webinar, you'll have an opportunity as well to hear from and learn from our evidence accelerators. This is a really exciting program that we've been running for a couple of years now, out of the School of Public Health. And we invite and engage with emergent leaders and scholars around the world on topics of gender equity and gender-based violence, take coursework and receive mentoring data labs from our faculty, and build connectivity as a cohort. And what they will be showcasing today is their culminating project, a mini project that they've developed in concert with their faculty and their mentors and their home communities, that really represents an opportunity to, again, bring that evidence forward in service of gender equity and gender-based violence prevention. And I'm extra delighted today that we will have an opportunity as well to hear some introductory remarks from one of our inaugural cohort members. And I'm going to turn us over now to introduce and turn us over to her now. I'm so delighted to be inviting Mobalaji, who is a senior lecturer and faculty at the Department of Epidemiology and Medical Statistics, the Faculty of Public Health at the University of Ibadan, Nigeria. Mobalaji was one of our first evidence accelerators, and we've invited her to give some remarks on how it has shaped her career and what she has been able to do thus far with the training. So Mobalaji, I want to turn it over to you now for those introductory remarks. Thanks.
Thank you, Michelle. Hi, everyone. I'm so glad to be here. And it's an honor to be one of the inaugural cohorts of the Evidence Accelerator Program, which has actually impacted me in many ways. I GBV Fellowship, and the program has actually helped me so much to build both technical and which was so useful at my institution. The Evidence Accelerator Program helped in boosting my confidence, especially in teaching and mentoring my postgraduate students, especially those of them that have interest in GBV research. So, I've been able to better direct them in the design of research in violence prevention and management. This program has also helped to accelerate my career by helping me to build more confidence and also have some more level of strategic thinking skills, which influence my leadership presence at my institution, where I currently serve as at various capacities. The program also helped in reshaping my career and future ambitions, especially in research, because recently I was able to put together, grant proposal in violence research, although I'm still hoping and unfunded. And also from my cohorts, I have a network of friends now, who have turned to peers, more like lifelong peers. We reach out to one another, for technical support and even research ideas and, skills in one way or the other. So it's a beautiful program, and the rich curriculum has so much, helped in doing a lot of things as regards my work as a faculty, and also even in my research aspect. So I'm so happy and excited to be here. It's an honor, to be part of your webinar today, and I can't wait to see all of you do exploits in the nearest future. Thank you very much. Thank you so much.
Well, Balaji, thank you so much for being here. Your presence really helps to shape the agenda and really kick off this webinar. And it's just so incredible to see what you've been able to do since the training. And we're just really thankful to have you in this space. So thank you again for those introductory comments. I am very pleased to serve as our moderator today as well. And what I am going to do next is introduce our first speaker. I'm really delighted to introduce Jigme Choden, who is a gender and youth program specialist at the UNFPA Bhutan office. She's going to be presenting today on contact, intimate partner violence, and reproductive coercion. And these are nationally representative results among ever partnered women ages 15 to 30 years in Bhutan. Jigme, over to you.
The topic of my study is Contact, Intimate Partner Violence and Reproductive Coercion, Nationally Representative Results Among Ever Partnered Women aged 15 to 30 years in Bhutan. My research question is: what are factors associated with contact, intimate partner violence and reproductive coercion among ever partnered women aged 15 to 30 years in Bhutan? Now, why this matters is because the World Health Organization multi-country study on domestic violence in women's health has documented that intimate partner violence is widespread. Lifetime prevalence of physical and of sexual intimate partner violence affects 15 to 71% of women worldwide. In Bhutan, 15.1% of ever partnered women and girls have experienced physical or sexual IPV in their lifetime. More than half of Bhutanese women and girls agree that man is justified in hitting his wife for one or more reasons. Reproductive coercion, which is a behavior that interferes with an individual's reproductive autonomy and decision-making, is pervasive, and it affects 1 to 19% of women globally in their lifetime for pregnancy coercion. When RC and IPV co-occur, it leads to devastating and long-lasting effects on women's mental and sexual and reproductive health and rights, like depression, sexually transmitted infections, and unintended pregnancies. No published studies currently examining risk factors for intimate partner violence, reproductive coercions, or their overlap in Bhutan. The objective of this study is to measure prevalence and identify risk factors to develop targeted support services and promote right-based solutions to achieve reproductive aspirations. This is the conceptual framework that has guided my research to understand the factors associated with lifetime violence experiences. On the left-hand side, I have comprehensive 11 sets of independent variables under broad categories of socio-demographic, physical health, reproductive, and geographical characteristics. The arrow indicates how these independent variables are hypothesized to influence the outcome of lifetime IPV, RC, and both IPV and RC. This study used data from Nationally Representative Household Survey in Bhutan, collected between May and July 2023. The analytical samples include 1,887 ever-partnered women aged 15 to 30 years. The categorical dependent variable was lifetime contact IPV only, RC only, both contact IPV and RC, neither as referent. The independent variables include 11 variables under socio-demographic, reproductive, physical, and geographical characteristics, as explained in my earlier slide. Data analysis included assessing frequency and distributions of independent and dependent variables, followed by bivariate analysis using chi-square tests to explore differences in lifetime violence experienced by independent variables. Subsequently, multinomial logistic regression analysis was also done to determine the independent effect of predictor and adjusted for potential confounder for those variables that were found significant in bivariate analysis. All data were analyzed using Stata version 17 with statistical significance set at 0.05. Now the findings. Among ever partnered women aged 15 to 30 years, 1 in 7 experienced physical and/or sexual violence, and 1 in 11 have experienced reproductive coercion. Among those who have experienced contact IPV only and RC only, few women, that is 1.4%, have experienced both contact IPV and RC. Both contact IPV and RC were more prevalent among rural women as compared to urban women. Self-reported disability, which included women who have experienced one or more forms of disability related to seeing, hearing, speech, walking, self-care, remembering, or concentrating, have experienced contact IPV and RC more than those who did not. The co-occurrence of contact IPV and RC was more than double among women with self-reported disability. Contact IPV was higher among women who have ever given birth, while RC was higher among women who have never given birth. In general, lifetime violence experience was higher among women who have ever given birth compared to women who have never given birth. This table shows the multinomial regression relative risk ratio. The bolding indicates statistical significance adjusted for all other variables in the table, and compare 3 specific groups of RC only, contact IPV only, and both IPV and RC. Those women living with partners show slightly lower risks for RC only compared to married women, with marginal statistical significance of p-value 0.07. Women in rural areas are significantly, that is 1.69 times more likely to experience our reproductive coercion only, and 1.36 times more likely to experience contact IPV only compared to women living in urban areas. Women who have never given birth are 1.9 times more likely to experience RC only compared to women who have given birth, and conversely, they are 63% less likely to experience contact IPV compared to women who have given birth. Women with disabilities are 1.38 times more likely to experience contact IPV only compared to women without disability, and this presence of disability is also a major risk factor for experiencing both IPV and RC simultaneously, with a threefold increase in risks. This is first of its kind study which has looked at the overlap of contact IPV and RC among young women aged 15 to 30 years in Bhutan. Women who experience contact IPV and RC victimization is slightly associated with various socio-demographic, health, and geographical and reproductive characteristics. Reproductive coercion is significantly higher among women who have not given birth compared to those who have given birth. In the current context of declining total fertility rate in Bhutan and also elsewhere in the world, findings suggest that social dynamics regarding family expansion may play a role in women's reproductive experiences. Now the next step. The findings provides new evidence for targeted and right-based interventions. It will support ongoing and future efforts in Bhutan to have the greatest impact by targeting individuals and communities with the greatest need. Programs must disaggregate and address the underlying socio-demographic, health, and reproductive characteristics identified as contributing factors to distinct forms of violence. To address the reproductive cohesion, expand access and autonomy by prioritizing rural women, youth, and those with disabilities and not given birth, empower with sexual and reproductive health education and agencies, strengthen healthcare system by proactively integrating reproductive cohesion screening within the clinical setting, strengthen staff capacity on trauma-informed training, establish clear and immediate support for survivors. On policy and advocacy side, work with policymakers on right-based approaches, ensuring pro-natalist approaches respect individual bodily autonomy. To address the contact intimate partner violence, implement Respect Women Implementation Package, a framework for policymakers developed in 2015 by UN to prevent violence against women, and it provides evidence-based 7 strategy for scaling a prevention program. Promote intervention that transform attitudes, beliefs, and norms to shift power imbalance between men and women and reduce the social acceptance of violence. Examples includes like collectively advocacy, utilizing platforms like 16 Days of Activisms against gender-based violence to raise awareness, group workshop and entertainment to build skills around healthy relationship. This study identified increased risks for married women, those with self-reported disabilities and living in rural area. So we need to focus on them. Early interventions to reduce reliance on abuser, mitigate financial stress, and strengthening relationship building programs. These are the articles that I have referred. Thank you.
Wonderful. Jigme, thank you so much for that. Absolutely so exciting to see some of these very first data come out. And thank you for that beautiful presentation. I invite everyone, as questions come to mind, go ahead and tuck them in the chat. We'll be handling questions all together at the end of the session. And we've devoted some time so that we can really have some crosstalk across settings and really do some learning application. So our next speaker, I'm delighted to introduce Saranzaya Gerelt-Od, who is a senior gender officer within the Asian Development Bank. And this is at the Mongolia Resident Mission. She is going to be presenting some really important results. The title is Understanding Men's Lifetime Non-Partner Sexual Violence Perpetration and its Association with Alcohol Misuse and Depression in Mongolia. So really bringing us to understand some of the patterns of violence perpetration and how they relate to underlying substance use and mental health issues. So really delighted to have you with us. Saranza, over to you. Thanks.
Hello, everyone. It's great to see all of you in this webinar, and I'm grateful to present my mini research project named Understanding Men's Lifetime Non-Partner Sexual Violence Perpetration and its Association with Alcohol Misuse and Depression in Mongolia. So why this subject is important is that gender-based violence remains a critical public health issue in Mongolia. According to the National Prevalence Survey on Women's Experiences, nearly 1 in 3 women, about 31% have experienced physical and/or sexual violence in their lifetime. Alcohol consumption is also a major global public health concern globally, contributing to an estimated 2.6 million deaths each year. Mongolia consistently ranks among countries with a high per capita alcohol consumption, particularly among men. At the same time, men's mental health in Mongolia is a growing concern. Rates of depression among men are estimated to be significantly higher than the global average, often linked to a strong social pressure to fulfill provider roles and to conceal emotional vulnerability. While most research has focused on women's experiences and victimization, this study shifts the lens to men. We examine men's use of non-partner sexual violence, I will refer later in PSV, alcohol misuse, and mental health outcomes with the aim of identifying pathways to support healthier coping strategies and prevent further violence for men. Globally, men's mental health following NPSV perpetration remains highly underresearched. However, existing studies suggest that perpetrators may experience shame, guilt, depression, and anger. Shame, in particular, is a known risk factor for depression and is closely linked to alcohol use and consent confusion, factors that may increase the risk of repeat perpetration. Against this all backdrop, our study aims to better understand how NPSV perpetration relates to men's mental health, including unhealthy coping strategies such as alcohol misuse and depression. So let me go straight to the key findings. The first figure shows men's self-reported use of NPSV during their lifetime to determine the prevalence of sexual violence. The results indicate that 13% of men reported having used NPSV at least once in their lifetime. The second and third pie chart present data on current alcohol misuse among men who participated in a self-reported survey. Figure 2 indicates that more than a quarter of men reported being unable to participate in daily activities due to alcohol misuse in the past year. At the same time, Figure 3 reveals that 23% of men say that they engaged in binge drinking, defined as consuming 6 or more shots of alcohol in one sitting, at least once per month over the past year. On the next slide, we reviewed the current depression levels among men. Figure 4 shows the depression rate among men at the time of the survey. Nearly 18% of men met the clinical criteria for depression during this period. So now we can see that men's use of NPSV in their lifetime, their current alcohol misuse and depression separately. However, it's important to see that how men's use of NPSV associated with their alcohol misuse and depression. So this table on the slide shows the bivariate analysis of NPSV with the alcohol misuse. The proportion of men who failed to participate in daily activities due to alcohol misuse was statistically significantly higher among men who perpetrated NPSV. As we can see here, 40% of perpetrators reported this impact, compared to 25.5% among men who did not perpetrate NPSV. This difference was statistically significant with a p-value of 0.03. We also found that monthly binge drinking was somewhat more common among men who perpetrated NPSV. About 36% of perpetrators reported monthly binge drinking, compared to 20% of men among non-perpetrators. This difference was marginally significant, with a p-value of 0.07. We also conducted a bivariate analysis examining the relationship between NPSV perpetration and depression. While depression was slightly higher among perpetrators at 22% compared to 17% among non-perpetrators, this difference was not statistically significant, with a p-value of 0.43. The result is not presented here. So when we analyze all of these, what is the next action is that all of these findings reveal that lifetime NPSV perpetration is significantly associated with the current alcohol misuse, both in terms of functional impairment and binge drinking frequency. This pattern highlights the need for integrated interventions addressing harmful drinking behaviors for men and youth, and these need to be as part of strategies to prevent further sexual violence perpetration by supporting better mental health coping strategies. The findings have also important implications for public health policy, particularly in the areas of violence prevention and substance misuse. Policies should prioritize screening for alcohol-related problems and violence prevention programs and incorporate behavioral interventions that reduce risky drinking patterns among men. And of course, gender-sensitive strategies that challenge harmful norms around masculinity and drinking culture are essential to reduce stigma and promote help seeking for men and boys. By addressing mental health and substance use together, policies can mitigate risk factors for violence and improve overall well-being among men. The one thing is that bivariate analysis between current depression and lifetime NPSV was not statistically significant in this sample. It is essential for future research to investigate whether perpetrating NPSV causally contributes to suicidal ideation and attempts, while also incorporating broader indicators of mental health beyond conventional depression scores. Such studies should explore comprehensive measures such as anxiety, trauma symptoms, emotional regulation, and substance use disorders to capture the full spectrum of psychological consequences associated with the NPSV perpetration. So this analysis uses the data from 2024 men's life experiences and use of violence in Mongolia household survey that was randomly selected, covering 399 men aged between 18 to 49, and data collection gathered across 8 provinces and 6 districts of Ulaanbaatar city in Mongolia. The methodology was adapted from the UN multi-country study on men and violence in Asia and Pacific. We conducted bivariate chi-square analysis to examine associations between lifetime NPSV perpetration, alcohol misuse, depression, with the depression measured using CASD scale. All analyses were conducted in STATA program. And thank you so much, everyone, and looking forward to having a Q&A session.
Wow. Wonderful. Thank you so much for that. We don't learn enough about men's perspective and men's experience in gender-based violence, perpetration and experiences. And so I think having an opportunity to hear about what's happening specifically to those intersections in Mongolia is just so critical. I know we're going to have a lot of time to discuss that. So, audience, please continue to circulate your questions in the chat function, and we'll handle those at the end. I'm really delighted now to turn us to our third speaker for today. I'm so thrilled to introduce Safiya Riyaz, Program Officer at the Asian Pacific Resource and Research Center for Women, ARROW. And she is going to be presenting today on advocacy strategies, specifically around the elimination of female genital mutilation and cutting, FGMC, in South Asia. She conducted a fantastic review on this, and we're really excited to do some learning together on this. So, Safiya, over to you.
Hello everyone, my name is Safiya Riyaz and I'm a fellow of the JHU Gender Equity, Gender-Based Violence Evidence Accelerator Fellowship, and my project is titled Advocacy Strategies Towards Elimination of Female Genital Mutilation or Cutting in South Asia, a review. I want to first begin by acknowledging that this work was made possible through gender support and guidance at the JHU Center. And I'm deeply grateful to my faculty mentor, Dr. Nicole Warren, and the faculty team for their guidance throughout this process. This review was guided by 2 core research questions, first of which was what key advocacy strategies have been undertaken towards eliminating female genital mutilation or cutting in South Asia in the last 10 years. And the second was what are the main gaps and opportunities for advocacy to accelerate the elimination of FGMC in South Asia. These questions set the direction for the desk-based review that I will walk you through today. Before I move into the findings, I want to briefly set the context. Female genital mutilation or cutting, or also known as FGMC, is defined by the World Health Organization as all procedures involving the partial or the total removal of the external female genitalia or other injury to the female genital organs for non-medical reasons. And recent global estimates indicate that over 230 million women and girls are affected worldwide. And Asia actually carries a far larger share of this burden than is commonly recognized and known. Current estimates suggest that the continent accounts for at least 35% of the global FGMC burden, affecting approximately 80 million women and girls, with the practice documented across 12 countries. including India, Sri Lanka, the Maldives, Indonesia, Malaysia, and most recently, Azerbaijan. My study focused especially on three South Asian countries, India, Sri Lanka, and Maldives, because they have each documented the practice within at least one community and collectively represent an emerging but critically underexplored sub-region in the global FGMC discourse. So why does this review matter? The United Nations Sustainable Development Goal Indicator 5.3.2 calls for the elimination of FGMC by 2030, with 2015 as the global baseline year. However, we are now 10 years on, and there is still no consolidated regional analysis of how these South Asian countries have progressed towards this target, and no clear picture of whether advocacy efforts have translated into concrete action. Civil society organizations and activists have been doing vital work on the ground, but their efforts risk being overlooked or dismissed by governments and stakeholders who sometimes overlook all the efforts that have been taken. Without capturing and documenting this progress, we risk repeating ineffective strategies and missing real opportunities to accelerate change towards addressing FGMC. Turning to the methodology of my study, the study employed a qualitative desk-based review to map advocacy strategies undertaken in India, Maldives, and Sri Lanka between 2015 and 2025. And documents were identified primarily through the Asian Network to End FGMC's organizational repository, and then was screened against a defined set of inclusion criteria covering geography scope, time frame, and language, which included English, Sinhala, and Tamil, and topical relevance and source type. The sample was also then validated with regional experts to ensure accuracy and contextual relevance. The analysis revealed 6 thematic categories of advocacy strategies that have been undertaken across the region. The first of which is media advocacy. This includes survivor testimonials and advocacy narratives that were delivered through newspapers, blogs, and social media. And a well-known example of this is a 2016 Al Jazeera article, Speaking with Survivors and Anti-FGMC Activists in India. Second theme was international collaboration and advocacy, including submissions to international monitoring processes such as CEDAW, the UPR, and the CRC. For instance, a 2022 UPR submission by women's rights groups in Sri Lanka that framed FGMC as reproductive violence. Third category was community-based advocacy, such as grassroots survival-led dialogues like safe space discussions in India, bringing survivors and community members to talk about this topic. And fourth was data and monitoring efforts, such as research on prevalence, survivor experiences, and community attitudes, including an exploratory study in Sri Lanka documenting the physical and psychosocial impacts on women survivors. The fifth category was legal reform advocacy, such as efforts calling for legal prohibition. And a landmark example of this is a 2017 public interest litigation filed with the India Supreme Court seeking a ban on FGMC. And the final category was health sector advocacy, which included efforts to sensitize healthcare professionals and oppose the medicalization of FGMC, such as activists in Sri Lanka recommending in 2024 that FGMC be included in the patient safety charter. And when you look at the distribution across the 56 documents that were reviewed, media advocacy was the most frequently documented strategy accounting for at least 27%, followed closely by international collaboration and advocacy at 25%. Community-based advocacy accounted for 18%, while legal reform advocacy and data and monitoring each appeared around 7 times. And health sector advocacy was one of the least represented at around 5%. For a finding I will come back to in a moment. And importantly, across these initiatives, I think what's very important to note is that the vast majority of this was led by women's rights groups and international NGOs. Government and Ministry of Health-led initiatives were strikingly minimal, and a pattern that cuts across all 3 countries. This really tells us something critical, because civil society has been carrying the weight of this advocacy largely alone in the past 10 years. And when we look at the country breakdown, India leads across all categories, which is partly a reflection of its larger population and longer civil society infrastructure. But it accounts for the highest number of community-based advocacy strategies and a significant share of media and international advocacy. And Sri Lanka and Maldives show important but comparatively smaller footprints, with the Maldives particularly active in media and international advocacy. The disparity across the countries also points to the need for stronger cross-regional solidarity and resource sharing. Overall, advocacy across South Asia has been successful in breaking silence, building survivor networks, and creating international and regional coalitions. However, alongside what advocacy has achieved, this review also reveals several critical gaps because domestic legal and policy change has remained largely stalled. Despite strong litigation efforts in India, no comprehensive legal ban is in place currently in any of the three countries. And parliamentary debates have been initiated in Maldives, but no real prohibition has materialized. And health sector advocacy remains thin and patchy because there is no government mandated guidelines or integration of this issue into the national health curricula. And awareness efforts for health care workers are also inconsistent. And I think one of the most significant gaps is the absence of robust data. Because without systematic monitoring, it is extremely difficult to measure whether advocacy has had any real impact on reducing the prevalence of the practice in the last 10 years. Based on these findings, the review points to several clear implications and recommendations across 4 areas. On the fragmented government response, I think it's very clear that governments must move beyond dialogue and then enact explicit legal prohibitions on FGMC in all 3 countries. But this needs to be done simultaneously with evidence-based dialogue with religious authorities, facilitated by both governments and civil society. And global accountability mechanisms should also be leveraged to hold governments accountable to SDG 5.3.2. Around limited monitoring and evaluation, there needs to be investment in technical and financial resources for data generation and monitoring, as this is urgently needed. There is also a real opportunity to integrate FGMC indicators into upcoming national health service surveys, which needs to be taken. And civil society organizations should also be supported, document and evaluate their own advocacy efforts systematically. And around poor engagement with healthcare system, international medical bodies such as the International Federation of Obstetrics and Gynecology, the International Confederation of Midwives, must take a clear stand against the medicalization of FGMC, where more and more healthcare professionals are undertaking and making the cut. And there needs to be a push for meaningful sanctions for healthcare professionals who are getting involved in this. And local ministries of health must also prohibit medicalized FGMC, and FGMC awareness must be integrated into healthcare services, including postpartum care. And on partnership and coalition building, there needs to be stronger partnerships with local civil society organizations and sustained investment in regional coalitions, which is key to ensuring that efforts are coordinated, mutually reinforcing, and not siloed within individual countries. To close, I think this review is a reminder that the work to end FGMC in South Asia is happening. Advocates, survivors, and civil society organizations have been persistent and courageous. But the scale of the challenge demands that governments, health institutions, and the international community to step up alongside them. And I hope this review can serve as a foundation for more targeted, evidence-informed advocacy going forward. Thank you very much, and I'm happy to take any questions.
Wow, thank you so much. Just such important analysis on the nature and the types of advocacy strategies that are underway and really showcasing their diversity. So, Safiya, thank you for bringing us up to speed on the many tactics that are being used And the cross-national, at the regional level, it really allows us to see some of the differences by nation, but within a region of great relevance for this topic. So thank you so much for bringing that to light through this program. We now really have a really nice opportunity for question and answer and discussion. And I invite people to drop questions into the chat. I'll be moderating these and turning to our panelists to move through our questions and have some discussion on this topic. As those are coming in, I actually want to, I'll kick us a couple of these off as these questions are coming in. And what I'd like to do actually is, Safiya, the first question really is for you. And I'm wondering, um, I'm curious what your thoughts are across the different strategies that were discussed in terms of the intensity that is needed, how long it takes. What have you seen both through the review and through your experience on sort of what is needed, how long the data advocacy, the coalition strategies, how do these strategies vary in the intensity that is required and the time that is required to really bring them forward? If you could give a few reflections on that, thanks.
Thanks, Michelle, for that question. I think that's quite timely in terms of the intensity and the time it takes, yeah. So I think there are a couple of things that kind of informs this kind of decisions, and throughout the review also this came out quite clearly, is that we're seeing a few worrying trends because the practice is also shifting, as I think of course, like the discourse is shifting and the way it's framed is also shifting. So for one thing that we're seeing quite strongly is that it's moving from traditional practitioners to the medical and clinical settings, which is a very worrying trend. So in terms of that, I think, so decisions like that really informs, one, the intensity in healthcare sector approach and the actors getting involved in that sense. So that is something in terms of the trends that we're seeing. The other thing is also robust data. So it's very clear that a lot of data, more robust evidence, because that is what's kind of the need of the time, and that governments really should put forward efforts to kind of bring this in to the national health frameworks and trying to identify, because a lot of the problem is also that within the Asian subcontinent, some of these is not really, it's quite silent in the sense that it's not openly discussed, and it's also happening within pockets of communities. So in that sense, there is the need to kind of pull this up, and I think channel the need for data. I don't know if that answers the question, but just a reflection.
Yeah, absolutely. You're really narrating how these strategies come together. And in your words, I'm also reflecting on just the translation function for media and for community dialogue to showcase that, I think you're saying as well, like this is happening, even if it's under the radar, not necessarily recognized or seen. And, bringing these all together, I think, is so powerful. What can you say as well? I mean, women's rights groups are at the forefront of this, and they have been for a long time, necessarily so. There's a call here for greater government engagement. What is your recommendation for, what additional supports are necessary or needed for women's rights organizations to continue to do this movement building and continue to carry this forward?
Thanks, Michelle. I think that was one of the things that informed the topic and the focus of the review as well, because for a long time, it's kind of, Asia has been on the sidelines, and there's this perception that it's not happening, or that maybe communities are not raising kind of the flag on this. But it's very clearly, we can see that since 2015, that this has been called out. But the need really is that it needs to be acknowledged, and it needs to be understood also, I think, within the frameworks of as violence against children, because that's who I think fundamentally is affected by it is children below the age of 7 and young babies. So we need to bring it into that framework, and governments need to acknowledge it as that. And of course, then bring it into the frameworks and identification as a violence against women and girls. So I think that is first and foremost the issue here, because a lot of the time in Asia, there is the tendency to kind of distance this as FGM. So there is a tendency to say this is actually not FGM, this is circumcision. So that kind of back and forth has really, I think, delayed and stalled the progress in terms of that. So I think governments need to very, very clearly define and acknowledge that this is what is happening.
Thank you for that framing on bringing it back within the broader violence against children landscape and some of the policy priorities and the discussions and the dialogue there, without losing the more focus on FGMC, also as a unifying and a point of recognition. So thank you so much for that. Let's see, I'm just moving on to a couple of other questions coming into the chat. The next one is for Jigme. Really thinking about, as we think about reproductive coercion in particular, really wondering about how do we balance some, and how does it play out that we're seeing at times very pronatalist policy, as well as the need to advance and respect women's reproductive autonomy. What are the next, tell us a little more about that, but also help us see what are the next steps? What's the opportunity to move forward there in a way that preserves women's and advances women's reproductive autonomy, and balances that recognition on where governments are sometimes coming in on heavily pronatalist policies. Jigme, thanks. Over to you.
Yeah, thank you so much for the question. The fact that in my study that the finding that 1 in 11 women actually experienced reproductive coercion. So particularly I was looking at whether women were getting pressured to become pregnant. And also a study saw that nearly significantly two times higher among women who were not given birth. So this is really significant within the current context of declining total fertility rate, not only within Bhutan, but also worldwide is going through this low TFR. And I think the government are really concerned about this low TFR. And the assumption often is that young people are deliberately choosing to have fewer children, and that women must be incentivized to make reproductive decision in line with national fertility target. But I'd also like to say that any pronatalist interventions, which is really aimed at reversing demographic trend, actually further risks of compromising individual bodily autonomy. In fact, this study actually this results argues for a policy shift, like instead of really chasing after the total fertility targets, I think we should work towards more creating a system. There are so many other just the incentive alone is not sufficient. We really need to create a enabling environment, like making parenthood more accessible and affordable, like promoting gender equal partnership in which women are not disproportionately responsible for childcare, or assisting young people in transitioning to adulthood with secure job, etc. But within all these initiatives, I think we need to prioritize and protect individual reproductive choices. Really, we need to enable all people to decide very freely on number, spacing, and also timing of their children, whether they want to have many children, few children, or none at all. Yeah, thanks.
Jigme, thank you. I hear you saying that it is possible to, respond to concerns about TFR, total fertility rate, and advance and secure women's reproductive autonomy at the same time. Is that what I'm hearing you say?
Yes,
Gosh.
Misha. Thanks.
I mean, creating that enabling environment, and then I noted in your slides as well, you had some recommendations on screening and just health sector responses for this as well. Can you help us bridge that in terms of what is necessary when we think about that enabling environment. What is the health sector role within that? Can you unpack some of those recommendations a little bit further?
Also in terms of um, strengthening the healthcare system, I think because we were seeing like the women who were not given birth were experiencing more reproductive cohesion compared to women who was given birth. So I think the universal screening, I mean, one size fit for all will also not going to work. For example, maybe we should have those kind of screening more within maybe a family planning or in the reproductive clinics, and we saw that like IPB is more among married women, so perhaps the screening might be more appropriate in the prenatal clinics. Yeah. And also from our other studies that our colleagues have presented, we've seen that one of the services that the women who are experiencing such violence is mostly going to they're availing the health service. So it's very important that our health services are really systems are strengthened so that this before it gets worse, that these women are also being screened, and also they're given proper referral and support services. Thanks.
Cool. Thank you so much. I really appreciate this discussion about what can be done in the health sector. And then also, what are some of the other policy solutions? I'm noting Saranza is chiming in the chat around. I'm just going to narrate this for those that are listening in. A similar situation in Mongolia where there is an encouragement for women to have more children. However, the education and health services are not always keeping pace. And an over focus on women's fertility isn't really getting us there when we're not looking as well at mitigating or decreasing that overall caregiving responsibility. Some of the advances that we're seeing in making childcare more accessible, in restructuring cities and built environments to reduce some of that caregiving burden, are part of that pathway. So it's exciting to see this come together across settings. I want to turn us, thank you, Jigme. I'm watching just some of our questions coming in, and I want to turn us over to Saranza and the Mongolia setting. I'm actually really, your study was so important in lifting up what's happening for men and the way that substance use, mental health, and violence can come together. One of the things that was most interesting to me actually is that there was a link with substance use, but actually not with depression, which is not always what we see around the world. So, what do you think this is about? Is it risk taking? Are there other types of pathways? What's on your mind in terms of explaining or understanding that a little bit further?
Well, thank you, Michelle, for a very crucial question. I think based on the given the sample covering 400 men across 8 provinces and 6 districts of UBCT, reaching out men's the national representative is very challenging in the country, and given the 3.5 million population. So then the 400 sampling is not statistically significant with that, perhaps. So the implication on that is maybe next research focusing on, the covering more sampling with the questions on depressions and correlations that could be the reflections so far. Yeah. So but the substance use is very statistically significant, because something like drinking alcohol in Mongolia is always their ranking, always the highest consumption in the countries globally. So there's something like we should the focusing on men's, especially the young people using substance misuse, that like in the further perpetration of the non-partner sexual violence perpetration would be the also the highlight for my research.
Thank you so much. And I'm wondering too, I mean, it's just such a wonderful opportunity to hear and learn from this really innovative large-scale study that was implemented, and it's so wonderful to have an opportunity to have that be to really showcase those results and include them within this webinar. What can you tell us about just the sort of the appetite for change and creating action around these findings? What are the first types of entry points that you see for really building on these results, addressing that connection of substance use and sexual violence perpetration? What is the starting point that you see for Mongolia and for the response on this?
Well, I think, it also tell us that prevention is very, very crucial, because drinking culture is something, we're in nomadic culture. It's like, the addressing mental health issue is not also, drinking alcohol is not the resolve your problem. So this is like, we have the thinking about men and masculinity, how like rigid masculinity among herder community masculinities, even both rural and urban communities are very crucial. And this is not also I illustrated in our research, but the NPSV among men perpetrated starting very young age, 15 to 20 years old after perpetrated. So this is really something like we really need to working on the young people and what is their the healthy coping mechanisms, how to stress relief, things like that is very something taboo in Mongolia because men seeking help is always a stigma around that. So that's like something we need to really focusing on men masculinity, rigid masculinity among herder communities, like entry points to further GBV program in Mongolia that I think.
Wonderful. Thank you so much for that thoughtful response. We're actually just right at the top of the hour. I want to invite all of our presenters for today to video on to just have a couple of final kind of closing remarks. I want to thank each of you for the incredible work that you shared and presented today. It's no small feat to run the analysis and pull these learnings together. I think we heard a number of themes across our really diverse settings. One of them is around norms change, and whether it is masculinity, whether it is recognizing and responding to FGM, whether it is handling reproductive coercion and pressure for fertility in rural areas, as well as urban, but also some of the rural areas. I think that you've also really lifted up some of definitely the unmet needs and the next steps in this agenda. But also really with this lens on some of our hardest to reach populations are the ones that can benefit the most from prevention and policy solutions. And I think I heard that as a thread throughout each of these presentations today. So as we come to a close, I just want to give a huge thanks to our audience for today, again, to our speakers, Mobalaji for joining us with your introductory remarks as an alum of this program. And I want to let everyone know as well that we'll be able to share out the recording from this session and look forward to really all of the work that will come from this. And thanks to everyone. Very impactful. Wonderful. Thanks so much.